Risk adjustment, clinical documentation specificity. Today we'll be talking about progress note documentation best practice, tips for success in risk adjustment data validation. Best practice for clinical documentation specificity. Why high-level details in your clinical documentation are best. Specifically, your clinical documentation must support the ICD-10 codes submitted on your claims, which reports the patient's care received and requires pertinent facts, findings, and observations about the patient's health and history to be documented in your progress note. Documentation of a patient diagnosis that is clear, concise, and uses high-level details to describe each diagnosis is critical for success in risk adjustment. It also facilitates quality patient care with better outcomes, accuracy of ICD-10 diagnosis code assignment to the highest level of specificity for claim submission, accurate risk score assignment, accuracy of the patient's complete disease burden, a portrait of health to CMS. It facilitates appropriate payments for all stakeholders. Remember, if it wasn't documented, it didn't happen. For risk score representation, the general rule is the higher the risk score, the sicker the patient, the lower the risk score, the healthier the patient. And specific to risk adjustment data validation audits, recall it's that one standalone progress note. It's not the medical record in its entirety that's used in an audit. It's the one data service and one single progress note that must validate the diagnosis code submitted on your claim. Specific to documentation and coding, some suggested best practice standards would be to develop an internal best practice rule for documentation standards that work at your facility. A standard rule for the MEAT, which is the CMS acronym MEET, that stands for Monitor, Evaluate, Address, and Treat. Beware of code specificity. Recognize unspecified codes. For a general rule of thumb, codes ending in 9 are unspecified. So when you see a diagnosis code ending in 9, consider further specificity if possible. The term history of. We'll look at the CMS definition and what it means in risk adjustment versus the way we were taught to document in school. Just repeating that each progress note does stand alone. It's not the medical record in its entirety, so the documentation in your progress note must support those diagnosis codes being submitted on your claim for risk adjustment data validation. Be aware of your internal informatics, the templates and note forms used in your electronic health record. Progress note output can be much different than your progress note input. So as you create a progress note and sign off on it, take an opportunity to review what the actual output looks like, because the output is what gets submitted in an audit. Attention to your active medical problems list for accuracy is important as well. Diagnosis accuracy allows for year-over-year ease. Use it to your advantage. It's system-driven descriptors and codes. Active chronic conditions to the highest level of specificity in the code and the narrative. Oftentimes the narrative in the active medical problems list is sometimes the narrative that appears in the final assessment in your electronic health record, so let's learn to use this to our advantage. So a best practice overview, clinical documentation for diagnosis coding to the highest specificity in risk adjustment data validation, also referred to as RADV. Why high-level details in your clinical documentation are best. High-level details in your clinical documentation provide the specificity needed to code appropriately and report your patient's true, accurate picture of health to CMS and diagnosis codes. The details in your documentation allow for diagnosis coding to the highest level of documented specificity to accurately capture your patient's health status. Lacking details in your clinical documentation cause unspecified default codes to be used, often not in the risk adjustment model. What are high-level details in documentation? High-level details are pertinent facts and findings and observations about your patient's current health status, as well as past medical history, in addition to your medical decision-making and treatment plan, which should be included in your documentation. Terms such as left, right, bilateral, upper, lower. My patient has an ulcer. What kind of ulcer? Is it a diabetic ulcer? Is it a pressure ulcer? My patient has diabetes. What kind of diabetes? Is it type 1 diabetes or type 2 diabetes? My patient has weakness. Weakness in what extremity? Is that weakness a residual effect from a stroke? So including high-level details to get to the specificity needed. What do high-level details in your documentation represent? The diagnosis code assignment to the highest specificity equals accuracy of patient disease burden equals your accuracy of risk score assignment equals accurate and appropriate funding. Documentation draws a self-portrait of your patient's health status, which is submitted to CMS and ICD-10 diagnosis codes on your claim. What's a risk score? A risk score is those patient demographic factors which are additive to the ICD-10 diagnosis codes in your documentation that map to an HCC category and any HCC interactions for accuracy of patient risk score. The healthier the patient, the lower the risk score. The sicker the patient, the higher the risk score, and we're overall going for accuracy of disease burden. So recall that standalone progress note in risk adjustment data validation and that CMS acronym MEET, monitor, evaluate, address, treat. Remember, it's that one data service and that one progress note that must validate those diagnosis codes being submitted on your claim for payment. So here's an overview of that CMS acronym MEET as what CMS defines to be clinical documentation best practice suggestion. Best practice are to ensure that each diagnosis coded is clearly documented as being monitored, evaluated, addressed, treated. So monitored would be including signs and symptoms of the diagnosis, the disease progression or disease regression. Evaluated would be looking at those test results, medication effectiveness and response to treatment. Addressed would be ordering tests, discussing of the diagnosis with your patient, reviewing records, counseling, and then treating obviously would be medications, therapies, and other modalities. Ensuring that you have high-level clinical details in your documentation, specifically the patient's diagnosis and the status of that diagnosis to the highest level of known specificity allows for accurate ICD-10 HCC code assignment and submission on claims. How to identify a code needing more specificity? In general, diagnosis codes ending in a 9 are considered to be unspecified. Other unspecified diagnoses: I-73.9, peripheral vascular disease unspecified, N-18.9, CKD unspecified, J-44.9, COPD unspecified. So trying to get terms within your documentation to further specify that diagnosis code. You can see here there's an example specific to diabetes. E11.9 defaults to diabetes mellitus type 2 without a complication, and that's really considered unspecified. We also have sometimes where we'll see E11X9, which is diabetes mellitus type 2 with another complication. It might say neurological complication or circulatory complication, and it's really what we want to do is further specify that out. Ask ourselves, what is the neurological complication? Is it diabetic peripheral neuropathy? That can code to E11.42. Or is it a circulatory complication of diabetic peripheral vascular disease? That can code out to an E1151. So oftentimes trying to specify those diagnosis codes ending in 9 allow for diagnosis coding to a higher specificity and could fall into a different risk adjustment category for HCCs. Specific to the American Hospital Association and the official coding guidelines, unspecified codes are codes titled unspecified and are for use when information in the medical record is insufficient to assign a more specific code. So here let's have a look at the CMS definition of history of. The CMS definition of history of often codes to resolved, gone, no longer present, a true past medical history. This is perhaps one of the largest obstacles to overcome in clinical documentation. Many times when you're going through your education, you're taught to use the term history of to mean my patient has a long-running history of a said diagnosis. Specific to CMS, history of means, again, resolved and gone. So try to document in terms of active versus using the term history of. So document that my patient has an active diagnosis of, or a long-term diagnosis of, or an ongoing, continuous, chronic diagnosis of. The actual definition from CMS says the use of history of in ICD-10-CM. History of means the patient no longer has the condition, and the diagnosis often indexes to a Z code that's not in the HCC models. A physician can make errors in one of two ways with respect to these codes. One error is to code a past condition as active. The opposite error is to code history of a condition when that condition is still active. And both of these errors impact risk adjustment. So refrain from using the term history of in your clinical documentation, specifically when it is an active chronic condition being monitored by you. Some best practice suggestions and standards around your active medical problems list. The active medical problems list accuracy allows for ease year over year. Use it to your advantage. It's a system-driven descriptor. Active chronic conditions to the highest level of specificity. Obtain those details in your selection for the active medical problems list. Narrative in the active medical problems list is typically the narrative that appears in the final assessment of your progress note, and you can use those details in the narrative to drive your clinical documentation. Use the active medical problems list to your advantage. It should be a true, accurate picture of your patient's health status. The highest known level of specificity in your diagnosis codes. Accuracy of disease burden, right? Choose the code and narrative to the highest level of specificity according to your patient's true picture of health. Get those details into the narrative and use those details to drive your documentation. So instead of an abbreviated version, here's some narratives that would typically be available in your electronic health record for selection. Instead of diabetic neuropathy, choose diabetes mellitus type 2 with diabetic peripheral neuropathy. And you can use those details in your clinical documentation to ensure that you're obtaining that diagnosis code at the highest level of specificity for submission. Instead of kidney disease, choose the stage of kidney disease. Chronic kidney disease stage 3A or chronic kidney disease stage 4. Instead of depression, choose major depressive disorder, recurrent moderate, and use those descriptors to drive your documentation for success. Current and active diagnoses relevant to the current care of your patient should be on the active problems list. Be as specific as possible, and again, use that narrative and the details in that narrative to drive your clinical documentation for success. Here's an example of a generic encounter form. There are 4 specific areas that are areas approved for code extraction and risk adjustment data validation. The HPI, the physical exam, the discussion summary, and the plan. For best practice, recall that CMS acronym MEET, Monitor, Evaluate, Address, Treat. So truly what we'd like to see and what would pass a risk adjustment data validation nearly every time would be to include your diagnosis in one of those 4 approved areas and what you're doing to meet that diagnosis, the status of that diagnosis and the treatment plan for that diagnosis. And then include that same exact diagnosis in your assessment for a 1-to-1 match as best practice. And then there's really no question. So you have your diagnosis in one of 4 approved areas for code extraction and that same diagnosis in your assessment, which is considered a 1-to-1 match for risk adjustment data validation. Ensure that you have those high-level clinical details in your documentation and then those diagnosis codes to the highest level of specificity assigned on that claim for submission. Here's just another example of the generic encounter form where we've highlighted those 4 acceptable areas for code extraction. So best practice would be to document your diagnosis and what you're doing to monitor, evaluate, address, treat that diagnosis in these 4 sections, as well as put that same diagnosis in your assessment for a 1-to-1 match. Regarding risk adjustment data validation, we are not allowed to take diagnosis codes from lists such as your problems list or your past medical history or your medications list. So that's why these particular areas of the progress note are identified as acceptable areas for documentation best practice. You know, the rest of the documentation in your progress note specific to the other areas shown here support your level of service and your medical decision making and your patient visit, but are not acceptable areas for risk adjustment data validation code extraction. So your diagnosis should not simply be listed in the assessment or the plan without further support of that acronym MEET. So you'll want to ensure that it's documented in one of these 4 areas and listed in the assessment as a best practice. So specific to a best practice standard for documentation specificity, for accurate reporting of ICD-10 diagnosis codes, the clinical documentation should describe the patient's condition using terminology that includes the specific diagnosis as well as the signs and symptoms or problems, reasons for the encounter. The diagnosis should again be spelled out in full as the final diagnostic statement in the assessment. The clinical documentation or source documentation, in this case the progress note, referred to by the coder, should describe the patient's condition using terminology that includes the specific diagnosis as well as the symptoms, problems, or reasons for the service. Specific to the American Hospital Association ICD-10 guidelines, for accurate reporting of ICD-10 diagnosis codes, the documentation should describe the patient's condition using terminology which includes that specific diagnosis as well as signs, symptoms, problems, or reasons for the encounter. So we want the diagnosis listed, the status and plan for that diagnosis, and then have that same diagnosis listed in your assessment for a one-to-one match. So the reason that we're mentioning including that diagnosis is many times we'll get clinical signs and symptoms. Maybe there's reference to a GFR without a diagnosis of chronic kidney disease and what the stage is. Or maybe there's reference to blood sugars, but there's no true diagnosis of diabetes. So, your clinical documentation around that diagnosis should include the actual diagnosis specificity as well. Some best practice suggestions for incorporating diagnoses from specialists. When your patient is seeing a specialist, be sure to incorporate the specialist's notes into your electronic health record. Add those diagnoses to your active medical problems list to the highest level of known specificity. And when you see your patient as the primary care physician, be sure to monitor, evaluate, address, or treat that particular diagnosis during your visit. Some examples of documentation for diagnoses that come from specialists would be, my patient has diabetic CKD3A, follows nephrology, it's currently stable, continue current treatment. Or my patient has chronic AFib, sees cardiologist Dr. Smith, currently no palpitations, will continue to monitor. Patient has COPD, controlled on Spiriva, follow-up scheduled with the pulmonologist. So it's absolutely acceptable to incorporate those diagnoses into your patient's active medical problems list so that you as the primary care provider can ensure that you are monitoring, evaluating, addressing, and treating those as appropriate throughout the year. So even when a condition is not presenting signs and symptoms, it's appropriate to evaluate that condition, controlled by medication, presenting no current symptoms. The condition still exists unless it's completely stated as resolved and gone. So we want the diagnosis, the status and the plan for that diagnosis, and then as a golden rule, list that diagnosis in the assessment for a one-to-one match. That concludes the presentation on clinical documentation specificity. Thank you for all you do. And just know it's the little changes that you make today that will make lasting effects in the future. We really appreciate you.